So keep it happening. When you were playing, just sharing. You can't start Zoom, right?
Right.
So I just basically put the iPad looking at the laptop on.
Okay.
And then I started the Zoom.
Okay.
When I started the Zoom, you read, it's like, oh, there's a laptop, and it just shared again. Like that. And then,
I always do.
Picture-wise.
maybe you know,
No, I have to hear.
Camera,
sorry.
Switch file.
switch camera, and it's the.
you know, and it'll already be set up the way it'll
Preset the way we built the school. He went into theater producer. Here it is.
I say use it as such.
The liveliness of the city.
All right.
Oh my goodness, thank you so
I
much.
don't know if you like I'm just gonna leave this hooked up into that, but otherwise you can change, the one thing I don't think that really always happens is it just being like. Yeah. Just in the order to wow. Yeah, so that's when you're hearing on the speaker.
Never know anymore.
Oh, yeah, oh, I'm in.
No, I meant like I never know if you do the handshakes or stuff.
Yeah, please do.
Yeah,
handshakes.
sorry. I travel around to different farms.
So I wouldn't have to have.
I don't know, it's always like, do you do it? Do you
You're
not?
good,
So,
you're
yeah.
Yeah. So are you both US?
Yeah, we have
Like I can.
Yes.
Yeah, I don't know if they said you want to do a link, I'll be able to. But yeah, you can monitor the chat room here.
So
You
do-
also, and I'm not sure, no, it's Justin, I wanna say.
Myself.
We see dollars.
But depending.
Did embellish it. Forgot training in it, but I'm not.
That's not like a research program.
But if you did, you could admit.
Yeah, because my main effort
When somebody else showed up and gave you the option, if you want to admit this person, I feel like I should.
But we have this.
Well, but you're claiming, no, that's what he's saying, you claim false. You're actually taking it from Australia. Whoever the host is there.
the center now, I think.
I have a-
Might
This
be-
is our world.
ETSU.
Yeah.
It's here, so I feel like we should.
You should be able to, you just need them. to
So it's not the College of Pharmacy, it's actually College of Public Health, which is where I
They can't let you. Okay.
with them and the
Okay, claim
college.
host, you can take that responsibility.
Michael Mead was somewhere here, up here in Chicago.
This is the extra layer.
Yeah, I think of the name.
And it doesn't have to be that, it's more like the
They
option.
had this grant
Yeah.
that come through for Rural
Yeah.
Health Center. And then they were funded that, I guess. it's you.
But you would literally, all you do is. And this is also, you keep this open. Hold on, please.
That's ETSU now, but it's pharmacy. It's pharmacy.
Keep this open, and as people join, they would pop up here.
Yeah.
You'll be like,
Okay. All right, so.
You're serious, Cam? I was in his wedding.
Yeah, yeah.
Yeah.
He was my
He's an
grad.
adjunct, and he's
He's
at,
adjunct, yeah.
the JCMC.
I'm just. He was my grad.
Yeah, from so Wisconsin.
Yeah. He was
So
my
he did his
grad.
master's.
Yeah, he did it under me.
And then I think he was working on
perfect. I mean, you, this doesn't have to stay.
GY2 while I was doing my fellowship.
You know where I'll be?
Okay.
Oh, and did you?
Otherwise,
we have the little online
Oh,
This
They
Have you ever seen one?
I will. I can text you right now.
We used to tell him, I say hello.
Like, there's a spot to put it. Otherwise, it's not working on my.
Oh, maybe that's why you didn't. It's just, you know.
They're doing much better.
Okay.
We're working on it.
Okay.
Someone in the patient.
Yeah.
Came to patient.
It took a couple of years to get it published.
Oh, yeah. You always told me.
No,
Don't worry.
No, I had it terrible. It should take me by flight direct.
I mean, you got what he wanted out of it, and you got his business skills.
Yeah, that's actually like the analysis.
I mean, you said that you were skills. You don't have to.
Yeah.
So
you were in Scotland doing.
So
Actually, I haven't. No, I had a.
He was really helpful.
I got in the big application and then they said they are.
Just not my alma mater.
Oh, well, last year, because you guys have the rock. Yeah, so she was sort of, yeah.
It's been a while.
Okay,
No, my
Haggard.
sister-in-law.
She did an amazing job. Actually, I
Watched
got
it.
a little bit more.
When I said,
Everything
you know, I
is
said,
agreed.
"What's
Yeah.
the time?"
And Bill said, "They're probably going to change and stuff."
Yeah. they go to-
Yeah.
We had an adventure.
No, it's Sarah's.
Oh, yeah.
Taking pictures.
Yeah.
That was the only.
So I did, you want to call from Kenya? Or do you want me to go?
We did, we, memorable. And we got ticket in the process. That's a good time, because we thought.
Right, this is, there's 10 minutes left, you still got 5, and then 5.
I get 4 hours. And then another 20 minutes. So, I'm glad I don't have to.
Where are we staying?
Other down the one this fall and then one.
That's what you start.
And they joined us.
Right.
And then centers sort of trying to bind it together.
Biology.
So that means I actually have
From some places.
Right. Belongs to the department. Yeah, so when like that person came and then
And I also
Oh, we did. Okay, so.
yes,
and then everyone. Like, yeah. What are you getting? I have to start. That's sounds good. Yeah, but I'm quite happy not to have to do the sort of daily HR. No, I had lots. You had lots.
But my son is a fish.
I exclusively talk about.
It was a company that was a dog out of New York City. We'll let you know. 100%. Even after it's done. I'm gonna work with you.
exactly.
No, we otherwise. So they want to come back to this.
It's Niall.
Thank you, Jason.
They're living in the Twin Cities, they're about 40 minutes away from.
Oh, great.
All right.
So welcome to our oral session. We're on Zoom, recording all of the orals. So we have 4 presenters this afternoon, about 15 minutes total for the presentation and Q&A, which is the fun part. All the slides are in order. So as you're ready to come up and present, folks, introduce yourselves. I'll be giving the presenters cues, 10 minutes left, 5 minutes left, 2 minutes left. And then we'll just keep the transition going. Sound good? And there's a microphone here. I'm gonna put it on just to make sure. But the room gets you this far. You got clickers and arrows.
Okay, excellent.
Thank you.
Tēnā koutou katoa. My name's Jo Hikaka and I'm here presenting work on behalf of the Māori Pharmacists Association. So the Māori Pharmacists Association is an organisation made up of Māori pharmacists, and Māori are the Indigenous people of New Zealand, comprising 16% of the population. Whereas our workforce, our pharmacist workforce is 1% of the pharmacy workforce, So Māori pharmacists comprise 1% of the workforce. So our organisation has a role in education, advocacy at the national and international levels, supporting universities as well as practitioners. And this work that I'm presenting is part of our first research contract that we gained through the National Health Research Funding Body in New Zealand. So I think I'm probably preaching to the converted here. Medicines are the most common form of therapeutic intervention in Western medicine, and adherence to medicines for the treatment of chronic conditions improves clinical outcomes. So in New Zealand, Māori are less likely than non-Māori to have access to high quality care across a spectrum of clinical contexts, and that includes access to medicines. Medicines adherence is an important part of access. So some studies report Māori to have lower adherence rates than non-Māori, but the drivers for that are unknown. And despite the World Health Organization stating that health systems and services are responsible for adherence, it's often postulated that personal or cultural factors are drivers for non-adherence in Indigenous populations. So our study aimed to explore Māori experiences of medicines adherence and Māori perceptions of the roles of pharmacists in supporting medicines adherence. So we used Māori research methods to undertake this work, and this included participants having the choice to contribute in Te Reo Māori, or the Māori language, and utilising cultural norms such as developing relationships prior to starting the formal data collection. We used wānanga as a tool for data collection. Wānanga are similar to focus groups, where we had facilitators and participants together in groups, but the basis of traditional wānanga is a real acknowledgement that the process is around knowledge sharing, and often with the aim of understanding issues better or creating solutions. As part of our wānanga, we shared information about the research, and participants shared their knowledge, and they also completed a questionnaire to provide further context around their responses. And in our critical thematic analysis of the data, we situated our findings within the political and social context of Māori. So we had planned this research in early 2021 when New Zealand borders were closed to international visitors and there were no active cases of COVID-19 in our community. So although we preferred in-person data collection, we had made provisions in our ethics applications for online methods. And that was lucky because we were in the process of starting our data collection when Delta arrived in New Zealand and we effectively weren't able to leave our homes for months. We had established ways of working within our research team that meant that we could respond in an agile manner to changes as they arose. We had 62 participants in our research participate, and they were in 13 different wānanga across 7 regions of New Zealand, and there were both in-person and online data collection because some regions of New Zealand still had no COVID. 44% of those people who participated in our research that took regular medicine said they were always adherent to their medicines, so they never didn't take it according to what was prescribed. Forgetting to take medicines or not having medicines on hand when people travel were the most common reasons for non-adherence. The next most common reason was intentional non-adherence, when people stopped or changed their medicine regimens because they were experiencing adverse effects. So interestingly, no one reported that it was a lack of trust in Western medicines or a lack of belief in medicines that was a reason for non-adherence. Our thematic analysis identified 4 themes relating to Māori and medicines adherence. The first, that medicines were an important part of wellbeing, but were just one component of holistic care. The second, that relationships with proactive pharmacists was important in supporting adherence. The third, that knowledge knowledge was the next theme, whereby knowledge was viewed as a privilege possessed by pharmacists, and the importance of sharing knowledge to rebalance power and to understand and to share that understanding. And the last theme was that participants had the ability to advocate for themselves and others in supporting in relation to medicine's adherence, and that family and social relationships and networks were important for medicine's adherence. So this is just one of the quotes from one of our participants. I think it's a good idea to be able to go to the pharmacy for a collective picture of your health and well-being. If you can have that kōrero or that discussion, that's part of rongoā. So rongoā is written as treatment, but it's sort of like rongoā can be used as a word for medicine, but it's also more holistic than that. It's to promote well-being and healing. So participants came up with a number of solutions to medicine's adherence issues, and these included those relating to cultural factors, functional aspects such as supplying medicines, adherence packaging, and clinical and regulatory aspects, such as ensuring medicines were well optimized so people would take medicines that they really needed to, and reclassification of some prescription medicines to enable access without a script. So we did this research as part of a sort of co-creation, co-design approach. As we were submitting our grant application, we had engaged national stakeholders to ensure they knew about this research, that we were engaging with them, and we have a stakeholder group that we engaged with throughout this research so that this information is being fed back in. And at the end of each of our wānanga with the different groups of people, we had a sort of a consensus gathering or building at each of the end of the focus groups. So we're ensuring we're feeding back and saying, look, in this focus group, this is what we hear as being the main things. Is this, are you in agreement? Are there any other aspects that you'd like to add in there? And so thanks to all the rest of the team who are back in New Zealand, and to all our participants. So this is really just a taster of anything I could talk about. So would love to engage with you more through this this week, talking about Indigenous methods, training community pharmacists as researchers. So the majority of our research team were community pharmacists with little to no experience in research. The Māori Pharmacists Association as an organisation, really keen to discuss if anyone's interested in collaborating. I'm here in the US for 5 more months. Based in Providence. We've had recent announcement that I'm a co-director in a Centre for Co-Created Ageing Research Excellence in the University of Auckland, and that's using arts, a really strong focus on arts-based methods to engage with older adults, so we understand issues important to older adults and also co-create the solutions. And that's engaging, and we talked about interdisciplinary work, transdisciplinary work earlier, but it's engaging with dance practitioners and engineers, because we're going to create a daily living lab where there's tech watching what people do and how they interact with products. So it's quite a wide scope of work in that. So yeah, also happy to talk about COVID in New Zealand, which really is a tale of two halves at the moment. So I'm happy to answer any questions. Thank you.
Hi, thank you so much for your presentation. Maybe I missed it, but what was the adherence scale that you guys used to assess adherence in this population?
So we didn't ask that. We just asked them, have you been adherent before? So we used the Moriski scale as a basis for. We did a questionnaire that we asked them to do after the wānanga. So after we had a discussion around what medicine's adherence meant, the Moriski scale is a basis to understand factors relating to adherence, but we'd also added in some factors of adherence or not, reasons for non-adherence into our questionnaire. We didn't want to give that to them prior to the qualitative data collection, because we just wanted to listen to their voices about their expression and experience of medicine's adherence. So we didn't ask them to say on a, how many doses of medicines do you? It was have you ever missed medicines? Have you ever? And we phrased it in the way, have you ever taken medicines in a way that's different to what's been prescribed? So trying to take that word, adherence out of the picture, and we've had that opportunity to have a discussion about the fact that it's just taking medicines in a different way, as opposed to it being, quite prescriptive, when you talk about adherence and people sticking to what the doctor says and that kind of thing. So we really wanted to try and rephrase that. And I don't know if anyone else has come up with a succinct way of doing that. We certainly haven't. So we, end up with a convoluted way of expressing that.
Thank you.
Thank you for a lovely talk and a very interesting part of work. I was wondering if you could you give us a takeaway message to bring to our students? What did you learn about medication adherence in this group that could be interesting for coming pharmacists to know when it comes to adherence in maybe Indigenous groups?
I think the takeaway for me was that people wanted to engage with medicines and they saw value in that, but that people were also able to say whether they felt that the medicine used in themselves was appropriate. So there were lots of examples of people changing the way they took medicines because they knew how it was working for them, and so I think it's so Māori expressed that medicine was still an important part of holistic care, but it wasn't the only thing. And so there was the need for pharmacists to accept that might not be the only thing, but it's certainly part of it, and for pharmacists to engage with those other practitioners that might support wellbeing in a more general sense.
Yes, wonderful presentation. Focusing in on the theme about the proactive pharmacist support, as I recall it, what struck you? What were patients talking about when they, when you captured that theme?
Yeah, it was really interesting. They talked about it from a sense of power. So they felt the pharmacists were in the powerful position. So they would be guided by the pharmacist about how that relationship developed. And so that's why they had, they were saying that the pharmacist had to play a proactive role. So, here's information about your medicines and we're going to talk about it. And this is, and I want to know more about you and I want to support you in this. So they felt that although they could make decisions for themselves, when it came to that relationship and the information that was offered, proactiveness, and then they weren't feeling like a burden, like, oh, am I taking away? They talked about observing pharmacists being really busy, rushing around and feeling like they were taking away time from other people if they were asking questions. So, yeah.
Thank you. I really found your theme of reclassification very interesting in your qualitative analysis, and specifically reclassifying medications as non-prescriptive. I assume that's what you're referring to. That would impact adherence. Can you elaborate on that?
Yeah, sure. And so we when we were discussing this, and we've got a paper under review in the sister journal at the moment because we've got a very fast decline from our set. So when we discussed that, we talked about the fact that there's probably two sides to that story. There are some medicines that, that require, they could be looked at and could be reclassified. For example, eczema creams to get them funded. So even emollients and things to get them funded without a prescription. But the fact that there was probably a requirement for increased knowledge around why medicines are prescribed, so that the quality and safety aspects of prescriptions and what's intended in a prescribing process, that there's a comprehensive review of the appropriateness of a medicine for a person, and that so that there's different levels of expertise based on that classification. So that was one of the things we thought about more broadly than rather people just saying, oh, we shouldn't need scripts, because there's more to it than that. Yeah.
Thank you. Moving from Dr. Hakaka to Dr. Waite.
Good afternoon. It is great to be here to talk. It's so fun to talk about your research and to get that feedback. So thank you very much for the invitation. Today I'm going to be talking about vaccination deserts, and I do research on pharmacist-based immunizations. That started just since 2013 in Canada, so fairly recent still. A lot of the work that I do is looking at how do we measure the impact of this pharmacist service. And so we take a look at vaccination rates, et cetera. So we've been able to demonstrate that we improve vaccination rates, specifically obviously with influenza, but with some other vaccines as well, that patients trust and accept pharmacists in this role. That one of the reasons that this has been successful is that we are geographically accessible, we have extended hours, and all the things that we know really make this work. So we spend a lot of time on these really positive outcomes and sharing those with policymakers and encouraging them to expand this role. But we do get pushback as to, are you really accessible to everyone? And how have you measured that? So this, we began actually looking at our pharmacist services broadly, not just immunization, even looking at just where pharmacists are, things such as the languages they can provide service in throughout the province. But one of the things we started talking about is let's look at a service and try to understand where are the pharmacists providing this service and how can we better understand whether we're serving all of the communities. And we know that, primary care health inequities already exist. So we've got data in Ontario showing that, physicians are not always as accessible in certain communities. Yet we really had little information about pharmacists and specifically around the immunization services. So this research was to examine the geographic availability of pharmacists with the authorization to immunize in the province and see if there are any gaps or what we call vaccination deserts, very similar to the medication deserts that we've also seen research about. So we have access to the Ontario College of Pharmacists database. This is all of our pharmacists who are licensed in the province. We have an agreement with them in terms of the data sharing. And so we collected information on the actively licensed community pharmacists. We looked at their injection certification status, as well as their place of practice and their number of hours worked. So we actually have very specific information about where they work and how many hours per week they work in that setting. We then wanted to characterize, of course, pharmacists work in multiple settings, so it was just not placing a pharmacist in a setting. You couldn't say that that was where they were working full-time providing those services. So we figured out a way of measuring pharmacist availability. So we looked at the weekly hours at each site of practice. We converted that to full-time equivalents. And then we also looked at that in terms of the relative to the population that was in that community. We then also took a look at those practice sites. We used our postal code to geolocate them. That allowed us to identify what we call the census subdivision or the community in which that pharmacy was. We were able then to identify all the FTEs associated with that pharmacy and begin to geolocate not only the pharmacists, but also the availability of pharmacists in terms of FTEs within those pharmacies. Because we use CSD, we are able then to classify these communities as rural or urban. Because we provide vaccinations on a public health unit basis, we then took the CSD, the individuals, and put them into public health units. And then we identified public health units as north or south. So you can imagine interesting process to go through and obviously lots of data, fun to do. Let's talk about the results. So we had 11,400 pharmacists in the province who are actively practicing. 75% of those pharmacists are trained or certified to, we say certified to inject. Most of the injections they do are immunizations. So I'm just going to simplify. I often will say immunizations. And we found that the pharmacist FTE to 1,000 population ratio in Ontario is 0.56. So we made the decision, if that's what was on average, is that we would be a little more conservative, and we called a threshold ratio of 0.5. So we're looking to see if these communities have a 0.5 FTE pharmacists per 1,000 population in order to be considered. We just said at or above threshold, because I don't really have any evidence that that's adequate, but it's just the measure we have. Below threshold and no availability with no FTEs at all in that community. So this is the first overview. These are all our public health units. We have 35 public health units in the province. And you can see that that green line is the 0.5 threshold. Again, just a comparative measure. But you can see most public health units actually are, sorry, I have to stop and think, is that 10 minutes left or 10 minutes? You do this, 10 minutes left, perfect. Most public health units meet or exceed the threshold. There are a couple of exceptions there. And you'll see on the far right, there is a north-south divide, and that's important. So, but you'll see that most of them, even in the northern communities, meet public health units and met that threshold. So we began to look at it a little bit more, and you'll see here the actual numbers, north versus south. It's interesting, there actually were more FTEs per 1,000 injection trained pharmacists in the north than there were in the south. And then we took a look a little bit more closely at rural communities versus urban, and you can see here's the difference. So rural communities are less likely to have fewer injection trained pharmacists than those that are in the urban communities. So we then translated that information over now to all of those public health units, and we looked at the individual communities within those public health units. And here you'll begin to see where some of the discrepancies are in terms of service delivery. Green is the urban centers within each public health unit, and and black is the rural. And you can see here that only 6% of the urban centers had less than that threshold, whereas 61% or 62% actually of the rural settings actually did not meet that threshold. We also then thought, well, wait a minute, we still have 25% of pharmacists who aren't trained. So what about if we train them all, we incentivize them, and maybe that would actually shift. So where are those pharmacists, and will that allow us to meet that capacity? Unfortunately, actually, I didn't give all the data here, but it really didn't change most of those centers. So most of the non-injection trained pharmacists actually were in urban centers. We also did we looked at the characteristics of public health units, trying to understand, which ones were more likely or less likely to have injection trained pharmacists. No big surprise with the first two larger populations and greater population density, whereas more availability of pharmacists. But the third one is interesting, and you'll see it on the map next. The greater land area meant there were more communities with no injection trained pharmacists. And so that creates an issue. And so if you don't know too much about Ontario, I'm going to give you a map. The one on the left is all of Ontario, and you'll see that black line sort of down to the right there. That's actually the north-south divide in our province. So actually, most of our province is north. Nobody in Toronto would know that. So a little bit like the Alberta, Ontario, we're very centric in Toronto. So I just circled one of our public health units there. The light green is no availability of injection trained pharmacists in those communities. And then the middle green is below threshold, and then the dark green is above threshold. Now, if you take a look at that 3562 public health unit, there also aren't many people. I mean, there was much of that area, there is no one, but there are communities there, and they do not have injection trained pharmacists. But I actually was more surprised with what I saw in the south. So if you take a look on the right side, that's a blow up at the south. And you'll see there are definitely a lot of dark green, but there are public health units with no availability of injection trained pharmacists. Now, of course, patients in those communities, citizens in those communities, can more easily access urban areas or centers there in order to get their vaccine. So it is a little bit different, and that's what I hear regarding the northern. It's not only there isn't any injection trained pharmacists, even if there was one and it was quite a distance, and that's, you can see the distance here, road conditions, weather, etc. They really have difficulty accessing those pharmacy services. And so injection trained pharmacists are just one example of the services that they will have difficulty accessing. So even though we have 3/4 of our community pharmacists authorized to administer vaccines, we do have vaccination deserts. And training the additional or incentivizing those additional 25% does not solve the access problem. We also, it's really those residents in rural areas, and they're all over the province. It was quite surprising. I would have picked some areas as having no access, and they actually had access. So it's not as logical, I guess, in my mind, when we began really digging down into individual communities. And then again, my comment that northern public health units and citizens in those areas may have additional challenges in being able to access services because of the geography that they have to navigate. So it brought me back to, well, what can we do about it? And I think we talk about this as a fantastic service. It is. I totally appreciate that. But this really is still not an option in some communities. There are not pharmacists there, or they're not trained. I really saw during the pandemic the unique collaborations that we really need to be working with. Public health units, but we have. Why not train librarians, or who are you going to train to actually immunize, and really getting into some unique models. of thinking about how do we extend vaccine research. And the final comment I'll make is that we began digging into this there were other layers to this, that many of these deserts also had challenges. They were Francophone communities who had fewer services being provided by pharmacists in the language of choice. We also had a number of communities that would identify predominantly as Indigenous, and that's quite common. And we really would like to do some work with the Indigenous communities to look at the data and help us interpret what does that actually mean, and of course socioeconomic challenges within those rural communities as well. So a lot more work to do, and very interesting area to take a look, do a deep dive in. So I'd be open to any questions. Thank you. Yes.
Thank you again for another brilliant talk here today. I totally agree that it's so important, this type of research that's looking into the social inequality part of it, and I think that's something that we need to do more. I agree with what John said earlier here as well about that. So it's so important. When it comes to sort of in the rural areas, how do you think it correlates with other types of accessibility? Do they also have poor accessibility to other health professionals? I mean, you could imagine that in the cities, the pressure on the doctors is really high, but it could, and they need more pharmacists to do vaccinations, but it's probably a problem in the.
It's a great question. I mean, and I think that's what we have to start looking at is a collective healthcare access. So in other words, maybe we don't care there's no pharmacist if there's a nurse practitioner clinic. I mean, it's really, I don't care who puts a needle in your arm, always my comment.
If they have access.
Right, it's access. So the group that we're working with at Laurentian actually has access to all the primary care physician data and the nurse practitioner data. So we're beginning to talk about how do we actually look at this as a collective and see if there's a way of looking. And we also have now access to all our pharmacy technician data because our technicians can immunize. So how does all of this come together and actually look at really service delivery, the big picture, versus picking out just one profession at a time and saying, hey, can we do it or not? It's really a question of can we all deliver it? So that is one of the, and it's hard because of course our data looks very different. So can they be combined or looked at together? And so we're just beginning to play with that to see what we can come up with. So great question.
Hi, it's a comment rather than a question, just in relation to your question there, Regan. So in the UK, interestingly, there's a positive pharmacy care law. So our community pharmacies are more likely to be located in areas of degradation compared with general medical practices. And there's a really good paper by Andy Husbands and colleagues from quite a number of years ago now that demonstrated this. And they call it the positive pharmacy care law because several decades ago there was the inverse care law, which was demonstrated for general medical practices in the UK, where you were less likely to have medical practices where the need was. So I think it's important also to look at as well as regional, but also national similarities and differences because we're not all the same. But it's really useful to see what you find.
There is this great work in Australia as well, and so I'd like to look at that.
Yeah.
We how do we incentivize? We heard from we also did some qualitative research with the pharmacists, and of course they said it's not just for us to get. I mean, how are we going to get trained? You don't inject virtually. So where do you run programs? You run them in, of course, Toronto. So you expect us to fly to Toronto with the cost of that, do the training, etc. So I mean, there are other models, and we have we now do better training methods for those individuals to access that type of thing. But it's thinking about it. How do we incentivize those rural communities to provide more care? We've even, somebody in Australia was talking, Lisa Nissen, we're talking about, why can't pharmacists do basic eye exams? Why, so there's a lot that can be done. I think it's the same. Why can't a dentist do the following or a dental hygienist do? So I really think we need to be talking, particularly with these communities, about how do we cross cover each other and that there be a core they had a neat model, a core set of skills that aren't all within your profession that all of these professionals would be able to do. So regardless of who is there, these core services for primary medical care would be provided. So anyway, it is interesting. I'll look at that. Thank you.
Thank you.
Okay, hi everyone. My name is Hattie. I'm a medical student from Anglia Ruskin University in the UK.
You are very soft spoken,
Oh,
so you either need to talk louder or you're gonna kiss the microphone.
Is this better?
It's being recorded, so I just want to make sure. That one is on.
Okay.
You might just.
I'll just shout a bit.
Yeah.
So our research was on community pharmacy provision in England during the COVID-19 pandemic, learning for future pandemic preparedness. So there are over 10,000 community pharmacies in the UK, and obviously, as with most of the National Health Service in England, there was a massive increase in pressure on community pharmacy throughout the pandemic. So this is evidenced by dispensing volume increasing by 22% in March and April of 2020. And alongside this, there were the addition of new services that pharmacies had to deliver, for instance, COVID vaccinations, COVID tests, delivering medicines to more vulnerable members of the population and things like that. And again, this was all exacerbated by an increase in staff absences throughout the pandemic. So the aim of our research was to explore community pharmacy service provision in England throughout the pandemic. And we were specifically looking at the experiences of key stakeholder groups, so patients and providers, in order to make recommendations for future pandemics. So the methods section of ours, we carried out semi-structured interviews with the key stakeholder groups in order to explore their experiences of pharmacy throughout the pandemic. The interval schedules were developed from the literature and were piloted prior to the study itself. We aimed to recruit patients from participants from 3 regions via flyers, emails, and social media. And we chose these regions in order to reflect regional and settlement differences. So once we'd undertaken all the interviews, we transcribed these, and a thematic analysis was carried out of the transcripts using NVivo 11 in order to find the main themes that have emerged. This was an iterative process with constant comparison between the groups, so that if any new themes emerged, we would go back and re-review. So I'm just going to run you through a few of the key themes that we had from the patient interviews. Obviously, there are quite a few up on the board. I'll just go through a couple of those. So with regards to the experience of community pharmacy by patients, the NHS England actually relaxed contractual opening hours for pharmacists in the UK throughout the pandemic. But none of the patients that we interviewed found this to be massively inconvenient for them. Some of them didn't notice a change at all. And those who did said that they were still able to access their medicines perfectly fine throughout the pandemic, as these opening hours were well advertised. And with regards to the availability of the medicines, they didn't find any particular change. And there was also no described changes in how their medicines were used as well. One of the participants did mention having to buy a blood pressure monitor, as the GP surgery wanted them to start reporting their results from home so as to maintain social distancing. But actually, most of the other patients said that if they were doing this, they were already doing it over the phone before the pandemic, so it wasn't a dramatic change. Obviously, I'm sure you know that throughout COVID, lots of new safety measures were implemented. So whether this is social distancing, PPE, signage, and things like that. And these were viewed entirely positively by all the patients that we spoke to. And those who commented said that they would be happy for the restrictions to carry on for longer if it was necessary. I'll just do the same, run through a couple of provider themes that emerged. So obviously, I'm sure you're not surprised that one of the major themes was the massive increase in pressure on community pharmacies. And this was because there are a lot of staff shortages, whether that be due to infection or isolation or furlough and things like that. That the staff shortages were very profound, and it did limit the timings of service provision in a lot of community pharmacies. So one of the ways that this was combated was altering closing times. So one of our pharmacy participants said that they were allowed to close 2 hours early in order to be able to catch up on the prescriptions that were building up. And they found that this was a helpful way of being able to alleviate the stress on the system. And also one of the other things that was quite evident was the massive increase in workload with regards to prescriptions, particularly early on in the pandemic. And this was attributable mostly to GPs issuing prescriptions that may not necessarily have been needed. One of the main ones that was brought up by quite a few people actually was inhalers. Obviously, patients are viewing those as being like critical because they're thinking, oh, it's a respiratory disease, we better get our inhalers. But some of the pharmacists were saying that patients who hadn't had an inhaler for 2 or 3 years were now requesting 2 or 3 inhalers from their GP. And because the GPs were overrun as well and they weren't seeing patients face to face as much, they were just issuing these with no review, which is obviously putting a massive strain on community pharmacies. We also asked them about the relationship with the wider health system, and there was a bit of a story of 2 sides for this one. Some people felt that there was an increased trust between pharmacy and other healthcare providers, mentioning things like logistical meetings with their local GP surgeries and stuff like that. But there were a few people who really didn't feel that it integrated very well at all. So you can see on the board, one person said that they felt abandoned by the NHS, by GPs, by the company, and by everybody as far as they were concerned. And it was also mentioned that it was quite difficult to get in contact with GPs as pharmacists were having to go through the normal telephone lines, which obviously completely overrun by patients who are panicking. And also some said that they felt that their clinical judgment was undermined as well, as referrals from community pharmacy to general practice weren't always actioned. So there was also a mention of double standards. For instance, pharmacists were being asked to take people's blood pressure now because the GP surgeries didn't want to. These double standards were actually mentioned by patients as well who had picked up on this. So we think it's a really key point that differences in like this care provision should be further explored to ensure that there's effective and equitable service provision in the case of future pandemics. Because could it just be that GPs undertake more work that can be performed remotely? Obviously, there was a massive increase in online consultations and things like that, and maybe that's just not available in terms of the work that pharmacists do. But also, why is it that pharmacists were being asked to take patients' blood pressure when just because the GP surgeries, didn't want that patient contact? What's the difference there? And also, it was kind of mentioned as well that patients were quite worried about going to the GP surgery and like catching the disease in the waiting room and things like that. But this wasn't mentioned with pharmacy. So I think the perception of patients was that it was quite different between the 2 service providers. As I mentioned earlier, the NHS England relaxed their contractual opening hours of pharmacies so they could close a little bit earlier if they needed to. And lots of patients the patients that we interviewed didn't find this to be inconvenient at all. So perhaps this would suggest a strategy for future pandemics if pharmacists were allowed to kind of catch up on their prescriptions and not get so overrun. And the last thing is that there were obviously clear surges in repeat prescription requests and authorization, particularly for inhalers, like I mentioned before. And we think this is one of the key areas that needs to be looked at for future pandemics, like how can this be managed? Is there a protocol that can be used so that there's more guidance for pharmacies and also GPs with regards to prescribing medicines, but also kind of tackling it from the source as well? And just, is there a way that we can reduce patients' fears into the effect that a disease is going to have on them or the security of the medicine supply chain? Because obviously none of the patients that we interviewed mentioned having any issues with getting their medicine. So why were they also worried about kind of panic buying, as it were, the medications and things like that? So that's the end of the presentation. If anybody has any questions.
I feel like I've been re-traumatized going through.
Sorry.
Remember, it really was tough for many of our colleagues. Did they talk at all about how often they had to change and adapt? Because we heard that from a lot of our pharmacists, not the patients too, but they were relying on pharmacists to help them navigate that, and that pharmacists found it very difficult to keep up with all the changes on top of everything that was happening. So I'm curious if you heard anything about that.
No, yeah, absolutely. So obviously I've just run through a couple of examples for themes there, but for instance, there were one about how pharmacists were saying there are lots of changes to the standing operating procedures that they had to keep up with, and that some of them just weren't physically possible. So for instance, one of them said that they had to do a thorough clean of the entire pharmacy every 2 hours. And they just said, well, that's physically impossible. We don't have time to do that. We can't even keep up with the prescriptions. So they were saying that while a lot of the changes were kind of well thought, like, well, coming from a good place and like would be helpful, they were just physically impossible. And that when making these kind of standard operating procedures, they need to be a little bit more considered as to what can these pharmacists like physically do, especially with all the staff shortages that lots of people were kind of taking on roles that they hadn't had to do before. And also lots of people were talking about the massive increase in the use of technology, and they were having to get to grips with kind of text message services that are going to ping out messages to all your patients and get them to come in and collect things, or delivery services. So yeah, a lot of them mentioned that there are like so many new things being thrown at them that it was hard to keep on top of it all throughout it.
I was surprised to see that that shortages didn't, medicine shortages didn't emerge as a finding, because certainly in Scotland in the first few weeks after lockdown, it wasn't a case of repeat prescriptions were being issued. It was prescriptions were being issued for 2 and 3 months supply rather than 1, and it completely disrupted the supply chain. And it did cause shortages. So when did you just say, when did you collect your data? Was it, you said at the start, but I missed it. Was it, I just wonder if it was a passage of time healed a lot of people's memories perhaps?
No, we conducted this quite near, when was it, this last summer. We were collecting the data from the participants, but obviously we didn't have a massive sample size or anything like that. And a lot of the patients that we were interviewing were elderly as well. So I don't know whether or not that could have had an impact, in that we just didn't have such a large sample size. But there wasn't, the people that we interviewed were obviously, as they were elderly, like it didn't really matter to them whether or not they had to go and collect their prescription a day later, because they weren't trying to fit it around jobs and things like that. So that potentially could have impacted the way they kind of remembered things. But none of the patients that we interviewed said that they had any trouble. Some of them said, oh, we had to go at a different time to get it, but a lot of them mentioned the text messaging service as well, which they found to be quite convenient, saying if it wasn't ready, we just went another day and we didn't have to go and be told that. We just got a little message saying, oh, could you come the next day instead? So perhaps that's why, but that we didn't come across many.
Thank you for a lovely talk. I was wondering, it's very interesting because you're a physician, right? Student for
medical student.
Medical student, yeah. So I thought it was quite interesting if the fact that you did this research into pharmacy is quite interesting for us, I think, because it gives us a different perspective also on our own profession. And have you learned anything that you're going to take into your own practices?
Oh, absolutely. At the start of this, I didn't really, if I'll be honest with you, know much about pharmacy at all. But I think it's really important, especially like having talked about the integration with GP. I would like to be a GP. So I think it's really important to understand it from both sides. And when I go on my GP placements, I always like say, can I spend a day in the pharmacy? Because I think it's so important to like understand how everything works. And obviously now I'll be a lot more conscious when I'm prescribing inhalers. I will not be prescribing millions of inhalers to every patient. So yeah, I've definitely learned a lot. It's been really interesting. I definitely think it's something all medical students should have to learn about.
Yeah.
Thank you, Patty. And yes.
Good afternoon, everyone. My name is Alina, and I will present to you today about African-born person living with HIV in Minnesota at the intersection of culture and the US healthcare system. This data was collected 4 years ago during my PhD dissertation, and right now I'm at University of Tennessee College of Pharmacy, Nashville campus. I'm an assistant professor. So just to give you some background about HIV and what's happening in the United States, but I will focus mainly on Minnesota because this is where the data was collected. As you might know, HIV became a more chronic disease state in United States because of the advancement of antiretroviral therapy and adherence to medications, which is very, very important in this population. However, in Minnesota, we have a more challenging situation in African-born population. African-born are not African-American. And it's very challenging to obtain that data from CDC. CDC classifies African-American, however, and are people who are born and raised in the United States. But these people, this population was born in Africa and they moved to the United States for other reasons. And the census do not classify them. I might get some data saying Black, African born, or you might lump them with African Americans. They represent, African born represents 1% of the whole Minnesota population. However, for the number of new HIV cases, the state is in an alarming state because 24% of new cases in 1% is represented by African born. Therefore, we have to integrate and understand what the issues are and how we can help them to access care, retain them in care, and also make sure they are taking the correct medications and decrease the burden for the state and also for the patients. For example, in 2016, the data is from 2016, when we had 24% of new cases in Minnesota, most of them were not virally suppressed, and viral suppression is absolutely necessary in order for them to have better outcomes and do not be contagious or obtain new disease states. So the main goal, one of the main goals of this study was to uncover the experiences of African-born people living with HIV who receive antiretroviral medications and their interactions with the US healthcare system. It was a qualitative study. I conducted narrative interviews during 2018. The recruitment occurred via flyers, which were put in different parts of the state, mainly in the pharmacies, HIV centers, and also HIV clinics. All the interviews took place face-to-face and were conducted until saturation was obtained. Each person received a $50 gift card. And after each interview, I sent the data for transcription, which was transcribed by a third party to avoid any biases. I used conventional analysis and I did inductive coding, which means I used the words from the interviewer, and all the codes were after that used based on similarities, created the categories and themes. 2 additional researchers reviewed all the transcripts and also the coding methodology, and the inclusion and exclusion criteria were mainly to be African born, to be able to speak English. I did not have a requirement for writing. And the reason is some people might not be able to write fluently or read fluently in English. They were taking antiretroviral treatment at the time of the interview. They were residing in the state of Minnesota, and they were willing to share their experiences about taking these medications. Exclusions, minors, non-English speakers, and people who were HIV positive, but did not take at the time of the interview antiretroviral treatment. However, I was not able to make sure to ensure everybody, whatever they mentioned to me during the interview, I had to take it for granted. I had no access to medical records. This is one of the limitations of this study because of the HIPAA law, and also the reason why I could not verify what they were taking, and also I had no access to hospitals to see what they were taking and if they were adherent or not. At the end of the study, as I mentioned, 14 participants were willing to share their stories. They came from 7 different countries from Africa. Most of them were diagnosed in the United States, but some were diagnosed maybe 10 or 20 years ago. I had a patient who was diagnosed 30 years ago with HIV in Africa. And 2 themes will be presented which are correlating with the aims for this study. Lessons learned from interacting with the US healthcare system and diagnosis secrecy. The main theme and the main thing which will remain with me for the rest of my research career was the interaction with the US healthcare system and the lack of trust in the healthcare system. For example, I had many participants who will be afraid to share their stories. They will be afraid to share their diagnosis with a healthcare professional. And I mean physician, pharmacist, health nurse practitioner, whatever you want. And I asked why is that I would say afraidness. Why would you be afraid to share information? Because they were coming from a different country where the healthcare system might not have the HIPAA law, where the rules might be there, but they will not be so stringent and enforced. And I remember one participant said he did not connect with the pharmacists because they were not doctors and they did not have that trust relationship. The pharmacist provided a business relationship, and it was more transactional. And I remember another participant mentioned he would never share their diagnosis with a pharmacist. And I said, but do you know a pharmacist would understand the medications you are taking, and they will they will acknowledge your diagnosis? And he said, no, they don't have to know what I'm taking. He will never disclose the diagnosis with a dentist either. So, and I asked, how can we merge the system to share your information? Because this is vital information, especially if we are thinking drug-drug interactions. And all I received was, I don't want anyone to know apart from my doctor. So how could we help them? And especially thinking of transportation, of food, of all these problems, how can we help them? I think creating a trustful relationship, and somebody mentioned to me, and this is pre-COVID, how a pharmacist could help them, having a private room where they could be consulted and talked about, but not to hear nobody else should hear what they are going through. And the second theme, sorry. The second theme was the diagnosis secrecy, which was very, very important for them to keep their privacy. And I remember mentioning, one of the participants said, if I knew the pharmacist would not share my information with anyone, would be great. And sometimes I think having a continuing education for pharmacists to realize this is a population where we can improve. And if somebody is from an African country, maybe we should mention, your data stays here. I'm not gossiping. I'm not sharing your information with anyone else apart from your physician or your healthcare provider. It's okay to share that information, but not with another friend or someone else. It's a lesson learned. And creating that trustful relationship, I had another participant who said if they will shake hands with me or they will be more friendly towards me and do not stigmatize me for my accent, the way I look, it will help me to create that trustful relationship. So some limitations for my study, the sample used in this slide cannot be generalized to all African-born patients with persons living with HIV in Minnesota, and some results might not reflect the full spectrum of this population perception with pharmacists in Minnesota community. Some conclusions, participants seemed willing to better understand and how to use the healthcare system for their own benefits. And participants are not using the pharmacists as a key resource for their medication information and might not seek the pharmacist advice how to take antiretroviral treatment. They could use this opportunity to engage this population to maximize outcomes. And one issue came always through the interviews, the insurance, the health insurance. And I know it's very challenging at the beginning of the year to go through health insurance. But if we, as a pharmacist, if we take time, 2 or 3 minutes to understand what are the issues, the adherence to antiretroviral must be 95%. Therefore, if we can help them and figure out how to get the health insurance sorted out, then there will not be a burden for the healthcare system. Some acknowledgements, this study was funded by Olsztyn Fellowship and the Doctoral Dissertation Fellowship from University of Minnesota. And I would like to thank my team, actually my PhD advisor, Dr. Schomer, Dr. Okoro, Dr. Rockwood, Cynthia Peter McAlpin, and Dr. Ranelli, and Dr. Larson, who was the clinical pharmacist who helped me to achieve this PhD. And thank you, everyone. Questions, yeah?
Yeah, just a couple. You want me? Okay. Thank you for that presentation. That was very enlightening. Really enlightening to see the population of Minnesota. I wasn't aware of that. A couple of questions. The first one, and then I'll stop. I can come back if there's time. You said you excluded non-English speakers. I assume the English speakers are the ones who had a further education before they moved here. Was that a finding?
Most of them were from an English colony.
A previously English colony. And so the ones who didn't speak English, there was no difference between, did you see if there was a difference in education between the one?
I had only English speakers.
Okay, so
I could not interview someone in French. I do not speak French.
Yeah. I just wondered if that had an impact on their relationship with the pharmacist too.
I have no idea what would have happened, but I don't speak French, so.
Right, I understand. Just wondering if some postulated reasons might be differences in education, and then that drives your relationship with your pharmacist.
Most people they had a very good English.
Yeah.
And I assumed I couldn't ask about the level of education, and you have to understand that we in this country, especially it was 2018, where we had a different political system, and some might be afraid to disclose how they moved to the United States,
right?
What was their status, if it's an immigrant or refugee. I did not go there, and this is the reason why I excluded to ask any questions about their income, about their social status, and I think this is a very
tricky area.
Very tricky area to ask questions about.
Yeah. I'll ask a second question later.
So, similar theme, but thank you very much for presenting this research, super interesting. But considering that, based on who you excluded, but was there anything in the qualitative information data that you collected where you asked anything about concordance, or did they mention anything about concordance with their provider? Maybe it's a provider they were familiar with because it was somebody who was culturally concordant versus the pharmacist in that area and cultural concordance or other.
Most of them trusted 100% the physician, and some of them were like, I'm going to the physician, I will not go to the pharmacist. And the physician was more kind of God for them. Whatever the physician said, they followed. When it came to the pharmacy, it's a transaction. This is what I'm getting out. Thank you, like, no, thank you, but give me the prescription. And some even said did not want to receive counseling.
Right, and
But-
so
but
did they
when
explain
the-
why that was, just other than their perception that the physician was God? Was it related to some other
It was more
factors?
the relationship and how the physician took that time to explain everything versus the pharmacist was like, oh, it's 2 minutes or 1 minute, here is your medication. And some of them refused to receive counseling, and I let it go. And I know by Minnesota law, you have to do counseling for each new prescription.
Sure.
And they said,
Right,
oh yeah, in Minnesota you had, oh, the pharmacist tried to tell me, but they refused it because they were thinking pharmacists are not doctors.
So they
And-
asked for.
And they are coming, some are coming with a preconceived mind. It's physician and then the other healthcare. But I think that the discrepancy was more when it comes to the insurance and what the problems are. If they did not get the insurance straightened out, they did not receive the prescription. So they went, the viral load will go up, the CDC4 counts will go down, and this is the problem. They will go admitted in hospital again. And this is how the cycle started.